My name is Malak Matoke. Malak works in Migori County as a TB coordinator. As you know, Migori is one of the high burdened counties in Kenya which are having a lot of cases of TB, especially this region of Nyanza. And if you look at the number of cases that occur in this region, Migori should be among the top counties that we need to take care of. So, for example, the whole of last year, we were able to report around 2,000 TB cases in Migori. These TB cases, most of them, the 60% of these TB cases were what we call bacteriologically confirmed TB. Those patients were taken to the lab, and they were taken the samples like sputum for gene expert, and they were able to produce results which were MTB detected, which we usually call that they were positive for TB. The other 40% is what we call clinically diagnosed. These are patients who are having TB like outside the lungs, outside maybe TB which is not happening in the lungs. As you know, most of our TB cases, usually 80% of them, they usually occur in the lungs, but there is another 20% of the TB cases that occur outside the lungs. Like when we have things like TB of the bones, TB of the spine, TB meningitis, maybe even pleural effusion. Those are some of the clinical diagnosed TB cases that we had. So far in Migori, we have 163 TB sites, which are TB sites which are either treatment or treatment sites, and also diagnostic sites, which are actively involved giving TB medication in those various facilities. Ideally, as you know, all government facilities are supposed to give TB treatment free of charge. So, but some facilities they have not been very active. But we have 163 active TB sites in Migori. This year with COVID, we have been having a lot of challenges. In that, patients, the cases have started going down slightly because most patients don't want to be associated with a cough, because they feel that if you have a cough, you are going to be tested for COVID. So, and it's like now they have shied away from coming to the facility, but we are trying to reach them and telling them that TB is curable and is preventable. So far, in the 163 TB sites that we have that are actively involved in TB cases, we have put strategies now there at least to try to capture these patients who are come to the facility. And we want to make it a mandatory that any person who comes to the facility who has an upper respiratory tract infection symptoms should be also tested for TB. It is free and it's very convenient. In fact, like for example, even today, even if you take a sample of your sputum, which we call okevo, once you take it to the lab, nowadays we don't use the microscope so much. There is a machine called gene expert machine. Once you put the Falcon tube inside, you put the sample in the Falcon tube. This thing is just that gene expert has modules. It's like a desktop like this, but it has modules here where you insert that specimen. So within 2 hours, you are able to get the results, and you can know whether you are having TB or you are having other problems. So we want to end TB by 2035, possibly. So for us to do this, we need to intensify our what we call active case finding. And that's what we have embraced in all our facilities, that any client who comes there should be actively screened for TB before even is treated for other elements that have brought him or her to the facility. In Migori, we have 8 sub-counties, and the 8 sub-counties we have here, every sub-county has a TB coordinator, the sub-county TB coordinator, who mans this program, starting from all the way Nyatike, Kuria, all these others. We have the officers whom we call the sub-county TB coordinators. They are the ones who usually go to the facilities, find out where the cases have been notified, and they register them, and they make sure that the patients are having drugs. The main challenge that now we are having in Migori is the number of DRTB, the drug-resistant TB cases that are on an increase. Like for example, last year we had around 24 DRTB cases. DRTB cases, what I mean here, these are the patients who have failed to the first line treatment. Like for example, the TB patients, the normal TB patients usually have treatment for 6 months, and others can have even up to 1 year, depending on the type of TB. So once they don't respond to this, they usually become resistant to some first-line drugs like rifampicin and isoniazid. And in this process, these patients end up now developing what we call drug-resistant TB. It is a challenge because you see we need to make sure that these patients are being taken care of, because they are going to be treated for 18 months. Imagine coming to the facility from Monday to Friday for 1.5 years. An average of 2 years, to be very precise. And you see now what it has in terms of your living, because you will be coming every day to the facility to get the medication. And the medication here that somebody takes can be even 15 to 20 tablets per day. So that's why we are saying that we are really having this challenge, that the cases are going up, and we're looking at how it will affect the other people outside, even the socioeconomic and all these other things is a challenge. So we are trying to work hard that we make sure that these patients get the preferred outcomes, so that at least they cannot infect other people. Because DRTB patient, if it infects you today, you will have the same strain. So meaning that you must also be treated, even if you never had TB before, meaning that you will also be treated for TB of this nature, and yet you are the first. It was the first time you are receiving you have had TB. So we are trying to do kind of advocacy to various places, like even the radio stations and everybody, at least to create awareness that TB is preventable and is curable. Once you have the signs and symptoms, come to the facility. Don't just go to buy drugs at the chemist across the counter, because in that process, most of the TB is just a bacterial disease. So if you go to the chemist and you buy an antibiotic, the signs and symptoms will just subside within a very short time, and then after some time they reoccur. So you will be having like that until by the time you are coming maybe to the hospital, it is too late. Then the outcome is that maybe you will be put on treatment and you die in the process. Ama you don't respond to the first line medication. So what we are trying to tell our people is that let them come to the facility whenever they have a cough. Let them come to the facility, and we get to know what is their problem. Other than the other problems, can it be TB? So that at least we can be able to do that. Otherwise, in terms of management, the TB management is very simple. Once you adhere to the guidelines, you take your drugs for 6 months. If it's a new case and you finish, you are following what we call dots. You can come out very clearly, very much cured, and you are done. And it's not that a must that if you had TB, it will also reoccur. So once you take the medication well, that is what happens, that you will get cured, or you get what we call treatment completed successfully.